Looks like it's 11:01, so let's get started today. We've got a jam-packed agenda for all you attendees. So good morning, everybody. My name is Jeff Foreman, and I'm with Unified Health Associates, or Alliance, UHA. Thank you so much for taking the time to attend today's webinar. And I hope that we're going to provide you with some valuable takeaways from this presentation. First thing that I'd like to do is introduce the other presenters this morning, and including myself, we have 5 other individuals. We have Lindsay Hurst from Linden Consulting. We have Mark Rensky from Highland Insurance. And we have 2 individuals from Enterprise. One is Mike Holman, and the other is Lisa Baker.
Thanks, Jeff.
Morning. And the last person that we have is, and certainly not least, is Steve Pearley from Next Level. So anyway, again, thanks for attending. I'll give you a little bit of an introduction about Unified Health Alliance, UHA. UHA, we've been established to bring together BH providers within the state of Ohio, and we're looking to negotiate agreements with the Medicaid MCPs, and we think that we have some real possibilities here with bringing together the combined assets of providers and getting their attention. And by extension, we hope to negotiate some really favorable agreements with these folks. So the agreements that we're looking at are really going to focus on 2 things. Performance contracting and care coordination. And these are 2 elements that are going to be starting, at least at this point, the State Department of Medicaid is saying, in early 2002. And the thing is, both these elements are going to really require significant investments in resources. And we're going to discuss some of these challenges in more detail this morning. So just, again, kind of giving you a basic overview of what to expect today. And I think without any further ado, we're going to present a little bit of a video for you for your viewing pleasure, and then we will get into the program. My background is I've been in the behavioral health industry for over 30 years, and I've seen a lot of changes over those years. We got to the point in 2010 where the state decided to go from Medicaid as being a cost reimbursement block grant type to a full fee for service. And then we got into 2018, and then we had another huge change. The state carved in behavioral health into Medicaid in a similar way that physical health, like primary care, has always been. What I think is going to happen over the next few years, I mean, obviously the big date is early January in 2022. Performance contracting, or funding for care coordination, and the reduction of fee-for-service is the main modality of payment. Those are pretty significant changes. And I appreciate the fact that providers are going to see this as kind of scary, maybe a little bit daunting. There's going to be a lot of work that's going to be involved in this. Things are going to become more and more data-driven. Not saying there aren't going to be some costs involved in implementing and maintaining them, but I would predict that there's going to be some real opportunity for financial margin here with both performance contracting and care coordination. I really see the possibilities of a better level of clinical care, better financial performance. I think overall providers are going to be healthier, our clients are going to be healthier. I just think it's a great thing for behavioral health. It's a great opportunity. Okay, without any further ado, we're going to start with our first panelist, and it is certainly my great pleasure to introduce Lindsay Hurst. Lindsay and her firm, Linden Healthcare Consulting, have had extensive experience in dealing with such items as measuring clinical quality, providing data analysis, and as kind of a function of all that, business intelligence. And Lindsay is working with UHA as an independent consultant, and she's going to help us establish these data systems. And we're very excited to have her. And so Lindsay and I are just going to do a little bit of Q&A, and hopefully after this, people who are attending will, have some better idea of what to expect during these challenging times. So again, Lindsay, thanks a lot for being here.
Thanks for having me.
Oh, you're very welcome. So, the first thing I wanted to ask you was, so you've worked with various aspects of performance contracting over the years, and I know mainly in the area of physical health care, but you have recently been quite involved with a number of BH providers. So, what can we as BH providers expect, to happen in this process that we're facing within, really less than a year?
Yeah, I mean, performance-based contracting came to physical healthcare, but before BH, we haven't really seen it hit BH yet. But I think that a lot of the lessons that we learned in physical healthcare are going to transfer over for BH. So at a high level, when we talk about performance-based contracts, we're always talking about tying payments to three key things. So it's the quality of care, the cost of care, and the patient experience of care. So we call this the triple aim of healthcare improvement. So high quality care in the most cost-effective manner and setting in a way that works well for the patients. So we know that any performance-based contract we're going to see is going to be focused around those three things. And usually they put the biggest focus on cost and quality because the patient experience is really hard to measure. So where it gets complicated is how we translate that into a managed care contract. And I say we, it's how they translate it. So how are they going to take that idea of rewarding high quality, low cost, patient-centric care and turn it into some measurable and specific metrics that are going to determine providers' payments? So with 6 managed care plans coming, I think providers should expect that every performance contract is going to be different. ODM specified that they want the majority of managed care payments flowing through these performance-based contracts. As far as I can tell, every managed care plan gets to decide how they want to do it. So between the different plans, you might see different measures, different reporting requirements, even if they use the same measures, different performance calculations and thresholds, and a different amount of money on the line. So regardless of those contract specifics, which we can't know yet, success under any pay-for-performance program is achieved the same way. So it's good patient tracking, good documentation, good data analysis, and the ability to make proactive outreach to patients around whatever your contracted measures are. So providers can start looking now at their care patterns and infrastructure and start thinking about how that might need to change if their payments aren't all volume-based and they're being held accountable to these other metrics.
Okay. So as you're saying, the details of the contracts will be different, but are there going to be any, common themes that we could see between the different performance contracts that you have worked with in the past, and what you expect to see really in this behavioral health environment?
Yeah, so I mean, at this point, we can only go on what's been published. But there are a few common ways that we structure these performance-based contracts. And ODM did specify in the managed care RFA which format they're wanting the managed care plans to use. So assuming that goes forward, the one that ODM picked has 3 basic elements. So first thing is we're still going to have a fee for service base. So providers will still submit codes for the work they do and get paid a set rate for that code. The rate might not be what it is now though. So they could lower that fee for service rate in order to account for other non-fee for service payments that they put in that contract. The second piece is there's going to be quality metrics with targets that providers are held accountable for in order to earn any bonuses. So these are usually the standard HEDIS or NCQA measures that people have probably already heard of. And then the third part is some sort of cost or utilization targets. So this can really vary from contract to contract, how they try to include the cost piece. Some examples I've seen would be actual cost per patient on average compared to their projected costs for those patients, or maybe your patient's cost compared to other similar providers, or certain number of services used by your patients, or possibly all the above. So there's a lot of ways to structure it, but the idea is if the provider meets or exceeds their cost and utilization targets and the quality scores don't suffer, then they get to share in the cost savings that they help create for that managed care plan. Flip side is if the provider doesn't meet the targets, they could have to pay back some of the losses. So the payback piece sounds scary, but starting out, the majority of the contracts are going to be upside risk only, meaning there's a bonus available that you could earn. And in some of these contracts, I've seen it be pretty substantial coming from the physical healthcare side, but the provider won't owe anything back for not meeting the targets. By 2025, though, if they stick with the managed care RFA as it's written, at least half of payments to providers with 150 or more Medicaid members are supposed to be under 2-sided risk contracts. So that means there's a bonus if you meet the targets and a payback if you don't. So that's a really different payment structure than I think anything we really dealt with before in BH. But it's also a real opportunity for high performing organizations to get reimbursed, not just for what you do, but for doing it well. So one other thing I'll mention here, I don't know if we're going to see it from these contracts or not, but sometimes you get a per member per month payment for all your attributed patients. So we're not talking full capitation where you take a flat rate for everything, but you get a small amount for every patient attributed to you as a way to offset if they do the lower fee for service payments, or just to incentivize different models of care. So right now, this is the direction I'm seeing a lot of performance-based contracting just generally go as a way to break that link between your volume of care and the amount of payment that you're getting for it.
Okay. So do we know some of or what the performance criteria might be that BH providers are going to be measured by?
Yeah, so we keep saying every contract's probably going to be different, but we do know a few things. So we know the quality measures that the managed care plans have to report back to ODM, and we know that some of their payments are tied to their quality performance. So I think it's a safe bet they're going to pick from those measures when they're contracting with providers. So there's 14 BH quality measures in that RFA that they have to report, but really only some of them would apply to any specific organization. We also know that the managed care plans get the biggest return on investment if they can keep their costs down without sacrificing those quality scores. So I really think they'll be focusing a lot on keeping patients out of high cost care settings, which for BH, that mostly means the ER and inpatient hospital. So they also know, the managed care plans know from their data, that members with BH and SUD diagnoses cost a lot more than their other members on average. And if they keep those members engaged in treatment, that decreases their overall costs. So I think there's going to be some sort of measures or initiatives around client engagement. It's really hard to guess how they might structure that piece because that's a little different than where we've been. But I think they're going to do something to try to help those members who have BH diagnoses but who aren't being treated by BH providers to connect with those BH providers and remain in treatment.
Okay. So another question is, what will the providers need to look for in terms of evaluating their data around, cost and clinical services?
Well, so the biggest thing to start out is just having access to the data. That might sound obvious, but with all the electronic health records and billing systems, a lot of the data that we actually need to do well in performance-based contracts is really hard to get at or might not even be available. So for starters, providers will need to be able to identify the patients that are attributed to them under each contract. So who does each managed care plan say is their responsibility for those cost and quality measures in the contract? So understanding who is attributed and why is step one. Then they need to be able to break down that population and figure out who needs what. So who isn't meeting a certain metric, like who had an ER visit and still needs a follow-up visit, or who's high risk of a hospital admission that maybe could be avoided with some outreach. Those are the kind of things that really help providers succeed in pay for performance. And the last piece, providers will need to be able to work with some outside data as well. So in the contracts, the managed care plans obviously have required data reporting from providers back to the plans. They also usually give data back to the providers though about their own members. So things the managed care plan knows from their claims that they think could help that provider. So maybe overall risk level or other providers the patient is seeing, recent admissions to the hospital or other facility. So providers will need to have a way to work with that incoming information from the managed care plans and connect it back to what they know about their own patients so they can target their outreach appropriately to maximize performance.
Okay, okay. So Lindsay, can you give the webinar participants a sense of what the care coordination process will look like?
A sense, maybe. Like everything else, it's all really still up in the air. So they had this behavioral health care coordination or BHCC program that was supposed to start July 1st, 2019, but they paused it and said they needed to revisit the strategy and program design. That's kind of all we know at this point. We don't have any more details of what exactly that's going to mean or when the program might actually start. Now, BHCC as a program is named specifically in the managed care plan RFA. So I have to think it's going to move forward in some format. We don't know exactly what it's going to look like. If you remember back though to the original BHCC when they put it out, it had basically all the same elements we've already talked about that are in these pay for performance contracts. So they would attribute patients to a particular BH provider. The provider would get a monthly payment amount for everyone attributed to them as long as they did certain outreach and care coordination. They could still bill for most other services and they got a bonus if they met quality and cost measures. So regardless of how they restructure it, I think those same elements will be there, and succeeding under that is the same as succeeding under performance-based contracts, generally.
Okay. And I think this question is probably something that providers are going to be thinking about because we all have different systems. But what can providers do really to ensure that their EHRs provide the required reporting for performance contracting and probably also care coordination also, but primarily focusing on the performance contracting element?
Yeah, so we keep saying every contract's going to be different. So I think the biggest thing is just going to be having some flexibility in those EHR and billing systems. So that might mean providers are going to have to document and track new data elements in the clinical documentation, which makes sense if we're thinking about quality of care metrics. But we also see the billing system sometimes used as a way to communicate non-payable quality data on a somewhat real-time basis. So billing is what we already have to communicate with these managed care plans. So they will often require providers to submit non-payable billing codes on their claims along with their regular charges to get credit on these quality measures. So that's something a little bit different, but it is something we saw in the original BHCC program design. So the EHR and billing systems will really need to be able to work with that. Another ideal feature would be some sort of population health-based patient tracking. So we talked a little bit about how providers need to be proactive to really succeed in these contracts. So the more support their EHRs can give them on that, the better. It might be built-in patient lists by certain conditions, or being able to write and run ad hoc reports for each of your contract measures, or My favorite would be if we have what's called clinical decision support rules at the point of care. So these are either pop-ups or notices, something to help remind your clinicians about documentation or care guidelines for these patients. And they're patient specific based on what you've documented in that chart. So there's all kinds of support that EHRs can offer. So I think providers right now should be asking their vendors what kind of population health or quality improvement features they have so that they can start digging into those, getting used to them, and seeing what's available before these contracts take effect.
Okay, great, great. That's a lot of information in a short period of time, but I think you did a great job of answering the questions, and again, hopefully, this will, I guess, engender some food for thought, and certainly it has for me. And so again, thank you so much for Lindsay for participating and providing, some examples of what your experience has been in the business. And, again, we definitely UHA look forward to working with you and starting really to flesh out some of the processes and dynamics that we're going to need to make this work. So thanks again.
Yeah, thanks, Jeff. I mean, it's a huge change for BH, but what I saw in physical healthcare was the early adopters really were able to take advantage and have a huge benefit from it. So I'm hoping the same thing comes to BH.
Yeah, I think that's always a key, getting in front of it and being an early adopter. There's a lot there to deal with, and it's a big change. So again, thank you. So we are going to switch gears a little bit here. Obviously, one of the things that I did want to discuss, and we brought in an individual to talk about some insurance issues. And there is a lot happening right now in the professional liability insurance marketplace. Some of you may be aware of it, some of you may not be aware of it. But again, I think all of you know that having good professional liability insurance coverage is really a core concept that's required for operating a BH provider. And so today we brought in a seasoned professional who will speak to these issues that are arising in the current procurement process for professional liability insurance. So I would like to introduce Mark Rensky of Highland Insurance. Mark is a insurance executive with years and years of experience in the professional liability area. I don't want to make him sound too old, but he has definitely worked for a number of years, and I've worked with him personally and been very impressed with his depth of knowledge and his ability to communicate with his clients. Just a little bit about Highland. They are a relatively sizable, I guess I'd call a regional broker. They have many different locations within the Midwest, and they are, again, on top of things and have a lot of good ideas in terms of how to deal with some of these challenges that we're going to be facing. And again, Mark will discuss the current environment and talk about ways of dealing with, again, some of the challenges that he is going to bring up in his presentation. So, Mark, if you want to take it away, and I think we're all anxious to hear what you have to say.
Great, Jeff. Thanks. I appreciate it. And I appreciate everybody's time today. Really coming at this from an angle, assuming a lot of the participants here are interested in the Unified Health Alliance perspective of, maybe going at things from a group perspective. Interestingly enough, the reason I guess why insurance is being brought to the forefront of this discussion is the commercial insurance marketplace, and that's what we do: professional liability, property and casualty. We also do employee benefits, health insurance as well, but it's becoming more and more difficult to secure terms and really just procure coverage due to the current market conditions. So, you know, the purpose of today, and I'm going to go ahead and share my screen here. What we'll do is I'm just going to kind of work off some slides of, because of the conditions, we are taking an approach for a lot of, whether it's behavioral health, human social services, or even, you know, child welfare type agencies, to try to, you know, rather than you as an end user, as an agency, if you will, purchasing insurance on your own, trying to band together to get with groups to essentially formulate your own insurance company that would be a risk pool for other like-minded homogenous groups. So that's the approach we're taking. We think it might be a good fit for those that might be interested in the UHA model, and we're trying to ultimately put that together. So kind of, yeah, I'm going to try to work briefly here, but, you know, kind of why consider this methodology is there has been a seismic shift in the insurance marketplace. Like Jeff alluded to, some of you might have seen that already, some of you might have not, but there's a lot of changes in the laws and legislation that has brought that. There has been some changes certainly in the social aspect of what's going on in the world that has brought insurance costs much higher. So we're going to just dive into that real briefly, like the who, what, where, when, why, and then what's ultimately is our solution. So as I alluded to, the conditions are just extremely hard right now. A lot of that is, you know, certainly to COVID-19, but a lot of this is just what you've seen in the news with a lot of catastrophic events: fires, quakes, tornadoes, floods. You know, pretty much no, you know, the area, I guess, in the country is immune to that. This is, you know, we have civil arrests due to what's going on in the world. Reinsurance costs are rising for the insurers. Investment income is down for the insurers. A lot of people don't realize that insurers don't make their money off of charging you premium. They typically make their money off of reinvesting their surplus. So this is all leading to tougher buying situations for you, the end user. We mentioned some of this. There's a huge, you know, increased litigation phenomenon with litigation financing, again, leading to higher costs for you. Social inflation, I think we're all aware of the stuff you see in the news, whether it's the Catholic Church or the Boy Scouts. These unfortunate incidents lead ultimately society to say someone has to pay for this, and they hold these, you know, organizations accountable, but essentially entire industries have to pay for it, and it's becoming very difficult. So I'm not trying to rain on how hard things are right now, but they are difficult, which is leading to why we're taking the approach we do. Some of you might have seen statute of limitations. This continues to lead to a tough market where there's very little capacity. Jeff, you know, being a longtime client of ours, understands some of the players. If you have tough exposures in whether it's, you know, children's services, which I know many of you do, a lot of these carriers are just no longer offering terms. So it gives you an idea of why we're trying to lead to a group approach. We expect this marketplace to continue for 2 to 3 years, being very, very difficult. You know, we're telling a lot of our clients and prospective clients that you should expect, you know, between 20% and 50% rate hikes in the next, you know, year or two. So all of this leads to, what do we do? What's our solution? And kind of brings us why we're here today. We simply think it is a great idea for many of you in your industry to band together and form what essentially is your own licensed insurance company, which would be owned and controlled by you, its members. So this is a group captive model. what, that's an intimidating word for some, but essentially a group captive insures or it can reinsure the risk of its parent and its members. And it really is, it's just a formalized mechanism of self-insurance. So you pool your money together to fund for your claims. And the benefit to it is, if you do it successfully, is that instead of passing off underwriting profits to an insurer, the captive or you all as its members retain that profit as you manage profitably. So that's what we want to do. We think it's a great model. We think it's a great model specifically for this industry and for the time. The why is, as I mentioned, the market conditions. There's a lot of frequency and severity in terms of claims right now. But simply put, other industries have done this prior to 20 years ago. The nursing home industry, you could not procure insurance. And so if you were a nursing home operator, you had to face the stark reality of either going out of business or paying 300, 400, 500% of what your normal premiums are, or investing in your own model. And that's what they did. And it worked very successfully. So that's what we're out to accomplish for you all. And a little bit more on the whys. There is a extreme potential for both short-term and long-term savings. Again, you capture that investment return instead of passing profit loading onto the insurer. It gives you the ability to control your own claims, whether claims get paid or settled or not. And it rewards those that are successful in managing their risk. So it's a great thing. It gives you flexibility. You can have your own captive cover whatever risk you do or you don't want to. And it also insulates you from the market conditions of what's going on today. So I don't know what our profile is of our attendees today, Jeff, but if we have maybe executive directors or CFOs on, I'm sure they understand the difficulties as you do and what's going on in the insurance marketplace. So we're really think this is a great concept for those to consider. As you can kind of see the spectrum of risk. This is what self-insurance versus, most providers are on a guaranteed cost program, is what you see kind of on the low end. And then as you get higher up on the spectrum, you see that's how you kind of take more skin in the game and go at this yourself. So, for, I would say, UHA prospective members, this is kind of the target member that we're profiling, those that have a strong balance sheet and have a strong culture and risk management and know how to manage their claims effectively. And if you sort of fit this profile, this would be an ideal scenario for you to consider. I guess I could get into some of the weeds, the timelines of how it works, but I'd say for the sake of today's call, trying to keep to a certain time, Jeff, hopefully I didn't run over my allotted time. I know I kind of went quick, but a lot of material to try to fly through in a short time. So that's kind of the gist of what we're thinking.
Great. I guess, no, appreciate it, Mark. And I think you did a yeoman's work in trying to articulate a fairly meaty topic in a short period of time. One question that I would have is, I know you've done some renewals recently. What kind of increases have you been seeing?
It's pretty difficult out there, depending on, again, your risk profile and your industry. At best, we're seeing 10 to 15% increases in rate and premium. At worst, we've seen 100%, 200%. Healthcare, behavioral health is a little bit, I would say, softer than, real healthcare, whether you're a senior living provider, hospital system, doc group, et cetera. Those groups are getting hit really hard. I just went through a May 1st with one of them, and it originally came in the 40% rate increase. So you're talking a group that was paying $300,000, they're looking at 420 to 450,000 for their premiums. So that's a tough pill to swallow. We do what we can to look at options, but it's very thin. The capacity is low. It's supply and demand. When the demand is high and the supply is low, it leads to difficult times.
Wow, that's some definitely some things to think about. And again, hopefully participants were able to get some idea of what we're collectively facing as we go forward. And again, a lot of this, obviously, as Mark said, is driven on external factors. So again, Mark, thank you so much.
Yeah, no, you're welcome, Jeff. I'm happy to participate. And certainly I tried to fly through a lot of that really fast. And if anybody has any questions or anybody wants to discuss further with me or you, they're obviously certainly welcome to. I feel bad for trying to fly through that topic, but I did the best I could in a short time.
No, we aim to get as much packed into a relatively short time frame. So thank you again.
Great, you're welcome.
So folks, I kind of realized that we bombarded you with a lot of stuff. And as you're probably aware, ODMH and the MCPs are, as we speak, continuing to develop the new contract provisions and various other changes that, again, are due to go into effect in January. And you can be assured that UHA will continue to monitor these things and report back out to you as we learn more and are able to structure our company to meet these challenges and help you meet these challenges. So without any further ado, I'm happy to say we've got a couple of what you might call less dense topics, no less important, but hopefully a little bit more cut and dry type items. The first one that we're going to talk about is a company car leasing program from the folks at Enterprise. And again, it is my great honor and pleasure to introduce Mike Holman and Lisa Baker from Enterprise. And they will elaborate on some of the features of the program that they have, and certainly will do it quite a bit more justice than I ever could without them. So without any further ado, Mike, Lisa, go ahead.
Jeff, thank you for the time. Lisa and I are excited to be a part of UHA and the offering that you're doing for providers. And it's an age-old question of for providers. Everyone's looked at: do we reimburse employees for mileage that they business miles they put in their own car, or do we give them a company car? And the some of the reasons why providers don't typically make that move is the fear of a lot higher costs, and then the administrative burden of running it. It can seem a little daunting to take on a fleet of vehicles, but there is a big trend in the industry of companies moving to company car programs and fleet programs with an outsourced provider like Enterprise. Enterprise Fleet Management's a sister company of Enterprise Rent-A-Car, and our focus specifically is on providing company vehicles for organizations like UHA that are comprehensive programs where we do all the heavy lifting and we negotiate on your behalf to make sure that it's as cost effective and as cheap as possible for that. And one of the perks and benefits that the providers get is partnering up with you with UHA is that you are working directly with Enterprise and doing all the coordinating and taking on all of the details of this company car program and providing it to them to be able to use for their organizations. So that's where some of the purchasing power and cost structure between UHA and enterprise. So helps make sure this is as efficient as possible. And we provide all the front end details of licensing the vehicles, making sure they're the right ones for the employees, as well as controlling the life cycle and then the back end process. All of those to effectively make these vehicles as safe as possible. So they can also be great recruiting and retention tools for employees and a way to increase benefits to them without having to incur additional costs.
Some of the additional programs will also include a maintenance program. Each driver will have access to a mobile app where they can set maintenance reminders, submit insurance claims for glass repair or replacement. They can also call roadside assistance, and it will also allow them to locate maintenance facilities where they will then show their electronic maintenance card to the shop. And at that point, enterprise team will be involved, will review the maintenance repair, give the approval, and also pay the shop direct. Then there's also a telematics program. This will allow us to increase driver safety and reduce the liability that each of the providers will have with this product. And then finally, a fuel program where each driver will be assigned a fuel card. They can still access any fuel station and purchase fuel by entering their driver ID and then the odometer. And all of this information then flows through to us to allow us to help track and manage the vehicle. And then finally, once we have all of the products and we're ready to roll it out, we'll meet with each individual provider to go over your individual details and discuss the best way to roll out the program to each of your drivers. And then once it's been rolled out, we'll then review the tools that you will have available to you to help manage the program when needed, along with us there to support you. Thanks, Jeff, for allowing us to provide a high-level overview of the company car program.
Great. Well, thank you, Mike and Lisa, for your presentation again. I understand there's a lot there, and we only have limited time, but certainly there will be the ability for folks on the webinar to ask questions. In fact, you can ask questions now. I believe we have a Q&A function. So if there is anything that people have thought about while watching this, please go ahead and if you would like, ask questions. And obviously, I'll reiterate later at the end of the presentation. But again, please feel free to get back with us on questions that you might have. So again, thanks, guys. Another opportunity that UHA can offer today is in the area of information technology. And we're going to have a gentleman on, Steve Perley of Next Level Technologies, who I've worked with for a number of years, and I can definitely vouch for his technical expertise and knowledge in pretty much all areas of IT, from getting your printer fixed to helping you with the whole development of business intelligence. So he really runs the gamut. So
you're too kind.
Well, I try to be, but I just you're a talented man. So and again, without any further ado, Steve, why don't you go ahead and take it away on the topic that everybody just loves, IT.
Yep. Well, hi, everybody. I promise I'll be brief. As Jeff mentioned, we're an IT services company that has spoken to and worked with a lot of BH providers in Ohio. And we've seen operationally, what your needs are, what your challenges are from, a staffing perspective to even IT connectivity, as I know a lot of you are providing, services in rural communities. And obviously, there's challenges from a cost perspective. And so we're partnering with UHA to help those of you that might need guidance around, what the right technology mix is for your team, or how to best leverage things like Microsoft Office 365 or Microsoft Teams, or, cloud phone systems or encrypted email, all that stuff that probably makes your head spin. We're going to be able to bring that tailored, kind of curated expertise to you guys through this alliance. And we're pretty excited. On the other side of the coin, we're going to be helping out with all that data requirements and the infrastructure that is going to be needed in order to pull the different data from your EHRs and marry that data to what we expect to receive from the MCPs, and then put it in a format where it can be turned not only into information, but into true business intelligence. And of course, this will be needed for the purposes of reporting for performance contracting and care coordination, but also for the purposes of long-term sustainability and helping your organization operate the best way possible. So, there's been a lot in this webinar, and that's a lot to unpack on, in itself, but we're just very excited to be a part of this. Thanks a lot.
Thanks, Steve. Appreciate it. We're actually at the point we're going to do a little Q&A, but does not appear that anyone has decided to submit anything during the webinar itself. So looks like we're at 47 minutes. And so we're, our goal was to kind of keep it between about 45 and 50 minutes. So I think we're going to do that. Again, feel free to reach out to me. We'll be, sending out contact information and all that after the webinar, and really look forward to questions, comments, concerns, compliments if you want to give them. Obviously, I hope everybody enjoyed the popcorn. So that'll be an opportunity to give us some feedback. So I guess in closing, I really want to sincerely thank all of you for attending this. I appreciate, you took an hour out of your day, and, that's no small thing. We're really excited about this, and in a number of ways, but really think the ability for providers to collaborate on this and really create the opportunity. It's really can be it should be an organic process, and UHA itself is here really to manage the contracts and metrics, help with report development, data analysis, all that. But the thing is, we really can't do it without you. This will really be based upon the provider network that we hope to develop, and we're seeing this as a great opportunity to generate top-notch clinical care. So again, sincerely hope that today's webinar was useful for you. Again, please feel free to reach out to me with questions and all that. So
Hey, Jeff, there is one question, and somebody asked, will this webinar be available for future reference? And the answer is yes. We will make the recording available.
Okay.
And if anybody else, maybe we didn't explain this, that there is a Q&A box at the bottom of your Zoom screen. If you want to ask a question, we'll hang on for a little bit longer. Sorry, Jeff, didn't mean to cut you off.
Oh, that's all right. That's all right. I was pretty much done. Again, if I know a lot of people, including myself, would be more comfortable probably asking it outside. So doesn't look like we've got any more coming up. So again, thank you all panelists. Thank you all participants. Glad we were able to get you out in 50 minutes, and I hope this was useful for you. So look forward to speaking with you in the future. And again, feel free to reach out.
Appreciate it, Jeff.
Thanks, everybody.
Yeah.
Bye-bye.
See you, everybody.
Thank you.